Dyspnea is basically an uncomfortable awareness of one's own breathing and is often the main symptom of cardiopulmonary disease, although the differential diagnosis extends beyond these two systems and is of sudden onset and therefore should be treated as a medical emergency. Cardiac causes include heart failure, um, coronary heart disease, valvular heart disease like mitral stenosis, aortic stenosis, and also cardiac arrhythmias and pericardial effusion. Respiratory causes are pneumonia, pulmonary embolism, obstructive lung disease like chronic obstructive pulmonary disease, that's COPD, and asthma, and restrictive lung disease, interstitial lung disease like cryptogenic fibrillizing alveolitis, and occupational lung diseases too, and also pneumothorax pleural effusion and chest wall function limitation in myopathy, neuropathy, and kyphoscoliosis. Other causes include anemia, psychogenic hyperventilation, acidosis, for example, uremia, diabetic ketoacidosis, drug overdose, and also foreign body aspiration and massive abdominal distension. Symptoms are breathlessness. The quality could be continuous or intermittent, and exertional suggests cardiopulmonary cause. Positional suggests paroxysmal nocturnal dyspnea, orthopnea, and also a cardiac cause. Nocturnal suggests cardiac or bronchial asthma. Time since onset normally is recent, that's acute, and if it is long lasting, is chronic. And the duration of episodes, it could range from minutes to hours, which suggests asthma, pneumothorax, pulmonary edema, pneumonia, and also anaphylaxis. From weeks to months suggest pleural effusion, pericardial effusion, pulmonary fibrosis, lung cancer, recurrent pulmonary embolism, cardiac failure, anemia, neuromuscular disease, and tuberculosis. Okay. If it lasts for years, then that's chronic obstructive pulmonary disease, COPD, and lung fibrosis. And associated features could be cough, which suggests acute heart failure and pneumonia. Also, sputum hemoptysis. It could be wheeze, that's in asthma and heart failure, and ankle edema, like in heart, kidney, and liver conditions. So the signs that are usually elicited include fever, in pneumonia, and less commonly pulmonary embolism, pallor, in severe anemia, acute heart failure, pulmonary embolism, myocardial infarction or cardiogenic shock. Others include sweating in acute heart failure, pneumonia, pulmonary embolism, myocardial infarction, clubbing in infections, cyanotic congenital heart disease, lung fibrosis, also cyanosis in hypoxia, for example in COPD, that's chronic obstructive pulmonary disease, in heart failure, pulmonary embolism, and pneumonia, also peripheral edema in heart, liver, or renal failure, and also wheeze in heart failure or bronchial asthma. It could be barrel-shaped chest in COPD, as chronic obstructive pulmonary disease. It could be ascites in cardiac, renal, gastrointestinal, hepatic, or intra-abdominal lesion. Also, the pulse could be fast, which suggests tachyarrhythmia and pulmonary embolism, or slow in bradyarrhythmia. Also, the blood pressure may be high, normal, or low. It could be heart murmurs too. which suggests valvular heart disease. Other signs include features of pneumonia, pneumothorax, and pleural effusion. Investigations are full blood count, urea, electrolyte creatinine, chest X-ray, ECG, pulse oximetry, and peak flow rate measurements. Cardiac enzymes like troponin, T, CKMB if ischemic heart disease is suspected, echocardiogram, lung function tests, spirometry, CT, pulmonary angiogram is useful for confirming pulmonary embolism. The main treatment objectives are to treat underlying cause and also maintain oxygen saturation above 95%. You can note that if there is underlying COPD, such patients could be dependent on hypoxic drive, so you have to be cautious of it. For non-pharmacological treatment, it's based on the underlying cause, and that's the same for pharmacological treatment. Referral criteria: you refer to the next level of care if the cause cannot be identified.